welcome to the Doctors in Training Pharmacology Review course. I'm Dr. Brian Jenkins, the President of Doctors in Training, and our goal here at Doctors in Training is to help you be the best medical professional you can possibly be. Whether you're studying to be a physician assistant, or nurse practitioner, we feel like this pharmacology course is the right course for you. So I hope you enjoy this lecture, and I know that it's going to help you learn more, save time, and be awesome.
Hello, I'm Dr. Michael McInnes. I'm an internist, and the lecture today is on Pharmacokinetics, Part 1. This is a foundational chapter. This is really a baseline for you to learn a lot about pharmacokinetics and pharmacology in general. There's a lot of vocabulary. There's a little bit of math, so don't get frightened by that. We're just going to get familiar with the basic concepts of pharmacokinetics more than anything else. So there are four main pathways that are involved in controlling a drug's onset of action and duration of action and intensity of effect. And the four main pathways are the absorption of the drug from the site of administration, distribution into interstitial fluid and intracellular fluids, metabolism by liver and kidneys and other organs, and elimination in urine, feces, and bile. But even before we can start talking about that, we need to talk about how do we get the drug into the system. So this is administration. The route of administration is really determined by a lot of different things. It's determined by the properties of the drug. Is it a soluble drug? Is it easily ionized? And also determined by what's the object of therapy. Are we trying for local effects? Are we trying for systemic effects where the drug is active throughout the body? Are we looking for a rapid cure? Are we looking for a long-term treatment that's going to be used for a long period of time? So really, when we're talking about administration, we're talking about two big categories of administration. The first is enteral administration, meaning using the GI tract, and the other is parenteral. Now, Lippincott, for some reason, talks about parenteral as meaning almost like using a needle. But parenteral really means all forms of administration that are not enteral, all forms of administration that are not using the GI tract. So talking about the enteral forms of administration. The first of these, the big one, is oral administration. You either swallow a pill or you swallow a liquid. This is obviously the most common route of administration for the vast majority of drugs. The advantages of enteral administration, oral administration, it's easy for the patients to do. If they happen to overdose, you can pump the stomach, you can give activated charcoal, so you can do something about the drug that's been overdosed. The disadvantages, as we'll see, absorption of oral drugs is somewhat complicated. It's not as straightforward as just giving a drug directly into the vasculature. Most of oral drugs are absorbed in the duodenum because there's a lot of surface area involved there. There are a lot of microvilli that provide a lot of surface area for absorption, a lot more surface area for absorption than the stomach, for instance. Other disadvantages of oral administration is that food and other drugs can interfere with absorption. Calcium, certain vitamins will definitely interfere with absorption, so you have to be careful when you're giving the drug to note whether or not it needs to be given with food or without food. Another disadvantage of oral administration is the hepatic first-pass metabolism, or the hepatic portal circulation. Drugs such as nitroglycerin, if they're given orally, are going to be taken up through the stomach and the intestine, and then they're going to go, the venous drainage goes directly to the liver, and the liver is actively metabolizing those drugs, including nitroglycerin, to an inactive form so that no active nitroglycerin actually gets into the systemic circulation. So that hepatic first-pass metabolism is a big problem for some drugs when they're given orally. Other routes of enteral administration include sublingual administration. This is where you dissolve either liquid or sometimes dissolvable tablets under the tongue. And there's a rich capillary bed underneath your tongue. If you look underneath your tongue, you see a lot of vascular markings. There's a lot of venules and capillaries under the tongue, and drugs that you dissolve under the tongue can be absorbed very rapidly and get into the systemic circulation. Now, I kind of question whether or not I would really call this an enteral administration. It's not really going through the true gastrointestinal circulation, or it's not being absorbed in the gastrointestinal system. It's going directly into the bloodstream under the tongue, but it's classified as an enteral administration. Drugs are rapidly absorbed, which is a good factor of sublingual administration. There's no first-pass metabolism because we're not going to the hepatic portal circulation. We're going directly into systemic circulation. Another form of enteral administration, which Lippincott doesn't list as enteral, is rectal administration, such as rectal suppositories. About 50% of drug that is absorbed through the rectum is shunted to the hepatic portal circulation, but about the other 50% goes directly into the systemic circulation, so that's very beneficial, that a lot of the drug will miss that hepatic first pass metabolism. We often use rectal administration of drugs for patients who are unconscious and they can't swallow, or patients who are having a lot of vomiting, and so you can't really give them a pill to swallow. You can give them rectal suppository. So a lot of antiemetic drugs or anti-nausea drugs are given via rectal suppository. Now, if you've got a patient who has both vomiting and diarrhea, then you've got a problem. You can't really use either end to administer the drug. We talk about parenteral administration. That's any other route other than the GI tract. We often use parenteral routes of administration for drugs that are not absorbed well, or drugs that are easily degraded in the gastrointestinal system. For instance, insulin and other protein or polypeptide drugs are going to be broken down in the stomach and the intestine before they can be absorbed. So none of that drug is going to be available. It's going to be degraded. You can also use parenteral administration in patients who are unconscious, and so they can't swallow a drug, or a patient who is uncooperative. Sometimes psych patients can get combative and they won't take a drug, they refuse to take a drug. You can give it parenterally, maybe an injection or something along those lines, to avoid that problem. You can also use parenteral drugs when you need a more rapid onset of action. If you give an IV drug, the blood is instantly into the circulation. You don't have to worry for it to be absorbed and so forth. So there are a lot of different routes of parenteral administration. First of all, there's the intravascular route, which means intravenous or IV, and rarely we use intra-arterial administration. Again, the drug goes directly into systemic circulation. There's no first pass metabolism to worry about. Unfortunately, on the downside of the IV administration and intra-arterial administration, you don't really have any recourse if you overdose a patient. Once the drug is in there, there's no way to get it back out. Also, it's kind of dangerous because you're bypassing one of the body's main lines of defense against invaders, and that's the skin. So you're opening up a hole in the skin to get the needle into the vasculature. And so you can allow a port of entry for bacteria, and sometimes patients will get infections of IV sites and that sort of thing. Patients are also very anxious about getting any type of IV medication or other injections. They're anxious about needles. They can be scared of needles. They're worried about it. So there's some pain involved and some anxiety involved that's worth noting. Other parenteral forms of administration include intramuscular, where you give an injection through the skin into a muscle, often in the shoulder, the deltoid, or sometimes into the gluteus. Sometimes these intramuscular injections are designed to be a rapid release, where it's going to be absorbed very quickly, or sometimes it's more of a depot formulation where it's going to be slowly released, and you might get effect of the drug for several hours, or even in some cases a few days. There are subcutaneous injections, where you are not injecting into the muscle, but just under the skin. Lots of drugs are given this way, including insulin, which we've already mentioned. Sometimes we give drugs intra-articularly, which means we do an injection into a joint. There are lots of different joints you can do injections into. Knees are common, shoulders are common. So you can give an injection into a joint. That's called an intra-articular injection. You can also administer drugs intrathecally or intraventricularly. Intrathecally means you are injecting the drug under the arachnoid membrane via a catheter that's placed by a neurosurgeon. So the drug is delivered immediately into the CSF. Intraventricularly means delivering the drug into the ventricles of the brain. You have a catheter that's tunneled through the skin and under the skull and then into the ventricles. So some examples of this would include amphotericin B, that's delivered intrathecally for cryptococcal meningitis, or spinal anesthesia is intrathecal delivery of an anesthetic agent rather than epidural anesthesia, which is where you're delivering the drug outside of the dura. Intraventricular administration of drug is also sometimes used to treat fungal infections of the brain. Other routes that are not really using needles or anything like that, other routes of administration include inhalation. There will be aerosol inhalers, you know, the little inhalers like you see kids and sometimes adults use for asthma. You can also use powders that are inhaled. Basically, you're using the large surface area of the respiratory tract and the mucous membranes in the respiratory tract in order to absorb the drug, or sometimes you just want a local administration of the drug right to those respiratory sites for treatment of asthma and emphysema and those sorts of drugs. In this case, it's more of a topical thing, so you don't have to worry too much about systemic effects, but sometimes you want the drug to get absorbed. For instance, they make nicotine inhalers for patients who are addicted to smoking cigarettes and they want to quit the cigarettes. They need the nicotine replacement to help them feel good and not have the cravings for cigarettes, so they inhale a nicotine inhaler, and then you're actually getting the nicotine into the bloodstream using the pulmonary vasculature to absorb the drug. There's also intranasal routes of administration where you have nasal sprays where you're spraying stuff directly into the nose. This is often a topical thing. Again, you have topical decongestants, you have nasal steroids, brand names you probably heard of like Flonase and Nasonex and Nasacort, very commonly used if you live somewhere where there's a lot of allergic rhinitis. So that's more of a topical use of intranasal administration. You can also give some drugs intranasally intending to have a systemic absorption. So there's a lot of vascular supply in the nasal mucosa, and if you give a drug that is absorbed in that vasculature, such as calcitonin for osteoporosis, vitamin B12 as an intranasal nose spray that you give once a week. You also obviously can think of cocaine as a drug that's often used intranasally. There's topical administration, which is very important. Again, we're looking for action right at the site of administration. So you put the cream on the skin because you want the cream to act right there where you're putting it. So we talk about skin. There are creams, ointments, lotions, and pastes that are used to administer drugs right to the skin. Other types of topical administration that are not listed in Lippincotts include eye drops or ear drops. Sometimes if you have conjunctivitis or infection of the conjunctiva, you'll use topical antibiotics. There are topical anti-inflammatories. There are topical analgesic preparations that you can put into an ear if you've got an earache. There's also vaginal suppositories and vaginal creams that are used for topical administration of drugs right to the vaginal area. Antifungal creams, estrogen creams, and that sort of thing. And then finally, the last route of administration to mention is a transdermal administration. Now this is different than a topical skin administration. Again, with the topical administration, you're trying to get the local effect of the drug right on the site of action. With the transdermal administration, you want the drug to be absorbed into the skin and absorbed into the systemic circulation. So you might use a patch, put the drug on, and usually these are patches that can be changed once every day, sometimes once every 72 hours, something like that. They also make some drugs in a paste that's designed to be absorbed into the skin. Typically patients who are having angina or chest pain from myocardial ischemia will be given nitroglycerin paste. So it's a constant infusion of nitroglycerin. And they also make nitroglycerin in a patch for routine administration that way. And again, with transdermal administration, it's usually for sustained delivery of these drugs. So most of the drugs that we're going to talk about throughout pharmacology are given orally. And so we need to talk about absorption. So absorption means transferring the drug from the site of administration into the systemic circulation, getting it from wherever you've given it, usually the GI tract, into the bloodstream. The rate and efficiency of absorption are very dependent on the administration of the drug. When you give a drug intravenously, all of the drug is absorbed. You're not really having to worry about absorption at all. All of that drug is going to get into the circulation. When you give it through any other route, just about, you have to wonder how much of the drug is really going to be absorbed and how much of it is going to be therapeutically available. Sometimes you don't want it to be therapeutically available, but often you do. So we need to talk about how these drugs get out of the GI tract. How are these drugs transported out of the GI tract? And the two main ways are passive diffusion and active transport. So in passive diffusion or passive absorption, the drug is passing through a cell membrane down its concentration gradient from an area of high concentration to an area of low concentration. So lipid-soluble drugs, or hydrophobic drugs, lipophilic drugs, can diffuse through the cell membrane very easily because it's a lipid bilayer, the cell membrane, so the lipophilic drugs go right through. Water-soluble drugs, on the other hand, don't go through that lipid bilayer very easily. They have to move through pores in the membrane, or channels, protein channels that have basically an aqueous center, so the aqueous fluid outside the cell and inside the cell just flows right through this channel, and the drug can flow through that channel as well. And then sometimes we have facilitated diffusion, which is where we have some type of transmembrane protein that's a carrier. It carries a drug from outside the cell into the cell, from outside the capillary cell and through the capillary and into the circulation. But still, even with these transmembrane carrier proteins, it's diffusion. It's going from high concentration to low concentration. It's passing down its concentration gradient. This is mostly used for large molecules that are just too big to pass through the cell membranes themselves. These carrier proteins can be inhibited. They can become saturated, which can limit the rate of absorption. But the vast majority of drugs are absorbed through passive absorption or passive diffusion. A small number of drugs actually have to be actively transported across the cell membrane. These are carrier proteins again, but they are carrying proteins from areas of low concentration against their concentration gradient to high concentration. And these carrier proteins in active transport require energy. They require ATP to be hydrolyzed into ADP, so they're using energy. And again, these transporter proteins can be saturated, which can limit the rate of absorption. A final method of absorption that's rarely used is endocytosis, and that's where you have a molecule that actually comes up against the cell membrane, and that cell membrane sort of pinches off a little vesicle around the drug and brings that drug into the cell. There's a good example of this. This is the way that vitamin B12 is absorbed in the gut, in the terminal ileum. Another factor that influences drug absorption is pH. Most drugs are weak acids, which means they donate a proton or a hydrogen ion, or they're weak bases, which means they accept a proton or they accept a hydrogen ion. And you see the equation on the screen. These equations help us to know how much pH is going to influence whether or not this drug is charged or uncharged. And you have to remember that charged drugs are not going to pass through the cell membrane very easily, where an uncharged drug will. So the pH of the surrounding environment, and we're talking about GI absorption, so the surrounding environment is basically going to be the gastric contents or the intestine, usually the duodenum. The pH in the duodenum or the pH in the stomach is going to influence whether or not the drugs are in a charged state or an uncharged state, and therefore influence whether or not these drugs can be absorbed. So we have to talk a little bit about the pKa, which is found on page 6 of Lippincott. The pKa is the acid dissociation constant. Each individual drug has its own pKa, and you can go look those pKa values up. The pKa is defined as the pH at which the amount of the protonated form of the drug equals the amount of unprotonated or non-protonated form of the drug. So basically the pKa tells us how strongly acidic or basic that drug is. And it's the Henderson-Hasselbalch equation that kind of helps us determine how the drug is going to concentrate in one compartment or another compartment. For instance, if the drug's in the stomach and it's trying to absorb through the stomach into the plasma, the Henderson-Hasselbalch equation is going to help us figure out what form of the drug is going to be around, and so which side of that membrane it's going to be concentrated on. Now, I know for some of you, when you heard me start talking about Henderson-Hasselbalch equations, your eyes glaze over and you're like, oh, I don't know about this stuff, or maybe you had a little panic attack and you freak out. It's like, Henderson-Hasselbalch, I don't want to get involved in that. It's like, the equation who must not be named or something. This is an important concept, but as a practitioner, you're not really going to use this. You don't have to worry about calculating this kind of stuff, but you might be tested on it. So you have to understand the concept, so you need to get familiar with it. So again, if the pH of the drug, or the drug's environment rather, if the pH of the drug's environment is lower than the pKa for that drug, then the protonated form of the drug will predominate. So if you look at that acid slide, the protonated form of an acidic drug is the acid, the HA. If you have a basic drug and the pH is lower than the pKa, then the protonated form is that BH, which is positive. If the drug is basic and the pH is low, that protonated form is charged. It's not going to cross the cell membrane very easily. Whereas if you have an acidic drug, the protonated form is uncharged. And so that uncharged drug will pass through the cell membrane fairly easily. Kind of to invert that, if you have an alkaline environment where the pH is higher than the pKa of the drug, the non-protonated version of the drug is going to be predominant. And so again, if you have an acidic drug, the non-protonated is the anion, A, which is negative, and that is charged. So that acidic drug is not going to be absorbed in an alkaline environment. But the non-protonated version of the alkaline, or the basic drug, the alkaline drug, in an alkaline environment, the non-protonated version is that uncharged base, that B, and so that drug is going to be absorbed more readily in an alkaline environment. Now, we're going to come back to acids and bases and pKa in part 2 of this lecture when we're talking about renal elimination, and at that time we'll be talking about the pH of the urine. But for right now, for absorption, you're thinking about the pH of the stomach and the duodenum. So still talking about absorption, let's talk about some of the physical factors rather than the chemical factors that can influence absorption. Blood flow has a strong influence on absorption. Obviously, the small intestine is a lot more vascular, has more blood flow than the stomach. But if there's stress or shock or strong sympathetic discharge, you may route blood away from the gastrointestinal system, and that's going to slow absorption from the GI tract. We have to talk about the surface area, and we mentioned this briefly earlier. The intestine has a lot of microvilli, which provides about 1,000 times more surface area for drug absorption compared to the stomach. So that's one reason that a lot of drug is absorbed in the duodenum as opposed to the stomach. We also have to talk about how much contact time at the absorptive site there is. So if the drug sits around at the site of absorption for a long time, a lot more of that drug is going to be absorbed. If you have a quick GI transit, for instance, a patient with diarrhea, the drug's moving through very quickly. It doesn't have a lot of time to sit around and be absorbed, so you're going to decrease absorption in that situation. On the other hand, slow transit time may increase drug absorption. And again, that's not always a good thing. Sometimes if you have a slow transit time because the patient's constipated, you're absorbing more of the drug than you want to, and you're getting increased toxic effects. So there's a lot of things that play into this. If you have increased parasympathetic input, that's going to increase gastric emptying, and that's going to increase the rate of absorption because the drug is going to move from the stomach into the duodenum and have time to be absorbed. Also, if you're giving a drug with food, that food is going to dilute the amount of drug that's in the stomach or the intestine, and so that's going to limit GI absorption and slow down absorption.
Okay, now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time for you to read your pharmacology text that corresponds to the material that was just discussed. Then together, we're going to go through the quick review in your study guide.
You are right on time! I just finished baking some of my yummy study cookies right out of the oven. Oh, not so fast. First, you have to answer a question. What kind of drug readily passes through the blood-brain barrier? Is it lipophilic or hydrophilic? Lipophilic is correct! I am so proud of you! Oh. Seriously? Seriously? We can't hire a decent hand actor? This is ridiculous. I can't be expected to put... You know what? I'm going to my trailer. Who writes this anyway?
Okay, let's go through the answers to quick review number 1. Number 1, where are most oral drugs absorbed? This is a duodenum, or duodenum, however you want to pronounce it. But in the duodenum is where most are absorbed. Number 2, what are some factors that can slow gastric emptying, thereby slowing the absorption of a drug in the duodenum? So there's several different things that can do this. I'm just going to list a few here. The first was mentioned in the lecture, which is to increase sympathetic output. So whenever you increase sympathetic output, this is your fight or flight response, that's going to slow gastric emptying, right? It's the opposite of rest and digest. So increasing sympathetic output. So what can do this? Well, exercise can do this, while you're exercising, of course. Strong emotions can do this. And then, of course, sympathomimetic drugs like epinephrine and pseudoephedrine and norepinephrine. Your sympathoplegic drugs. Other things that can slow gastric emptying include drugs that can decrease parasympathetic output. So not having rest and digest. So it's the case that we learn fight or flight and rest and digest, but when you're talking about pharmacology, it's pro-fight or flight or anti-fight or flight, pro-rest and digest, anti-rest and digest. And in this case, we're talking about decreasing rest and digest, decreasing parasympathetic output. So what drug can do this is atropine. Another thing that can slow gastric emptying, very common disorder, is diabetic gastroparesis. So it's basically your pyloric outlet does not allow food to go through because it's not innervated very well. It's almost like you have a peripheral neuropathy or neuropathy of your gut, of your stomach. And so diabetic gastroparesis is a problem that can cause this. And then, of course, just ileus in general. If you have post-op ileus, or commonly ICU patients will have ileus, that can also slow gastric emptying. Number 3, what is the key difference between topical and transdermal administration of a drug? So both, you place the drug on the skin, so you might think they're pretty much the same thing. In some regards, they are, but there are distinct differences. So with topical administration, you use this when you want the drug to act locally. It's like when you have a cut and you put some antibiotic ointment on there, that's topical administration. Or if you have psoriasis and you're putting steroid on there, that's topical administration. With transdermal administration, you want the drug to be absorbed through the skin to have systemic effects. So this is when you put an inch of nitro paste on a nitroglycerin paste on a patient that's having chest pain, and you occlude it with something. The occlusion of a topical agent makes it more likely to be absorbed transdermally. You also have transdermal patches. You can have pain patches. Of course, there's oral contraceptive patches. These are all dosed transdermally as well. Number 4, how are most drugs absorbed from the GI tract? This is by passive diffusion. Number 5, briefly describe how B12 is absorbed by the body if administered orally. So the absorption of B12 is important to know for a lot of your standardized tests going through your medical professional training. So just the quick overview is B12, you swallow it, goes to your stomach, and in your stomach vitamin B12 binds to intrinsic factor, which is made by parietal cells. This complex of vitamin B12 plus intrinsic factor then travels through your gut all the way to the terminal ileum. Nothing happens to it until it gets to the terminal ileum, and that's where vitamin B12 is absorbed. If it's not bound to intrinsic factor, it's not absorbed. So if you have loss of parietal cells, so that you don't make intrinsic factor, then B12 is not going to get absorbed. If you don't have a terminal ileum, then B12 is not going to get absorbed. So in those instances where if you have a B12 deficiency and you can't take it orally, you're going to have to get it some other way, and commonly you can give B12 intramuscular injections. Number 6, which form of a weak base will predominate when it is in an acidic environment such as a stomach, and in which the pH is less than the drug's acid dissociation constant, also known as a pKa. So if the pH is low, so acidic environment, lots of hydrogen ions, but more importantly, if the pH is less than the pKa for the substance, then the protonated form is going to predominate. And if that's an acidic drug, that means that protonated form of the acidic drug does not have a charge. But in this example, we're talking about a weak base. In a weak base, in a low pH or pH less than the pKa, it's going to be protonated, and it will have a charge with it. It's a cation, a positive charge. Number 7, how would corticosteroids be administered for each of the following diseases? So I have this question in here just to reiterate that the way a medication is given is very important. And one particular medication can be given lots of different ways to treat lots of different diseases. Steroids in particular is one of those medications. So keloid scarring of the skin, this is where you have a lot of collagen deposition, typically in the upper chest, face, earlobes is a common location. So corticosteroids can inhibit the deposition of collagen and reduce the size of that keloid scarring. Anyway, this is a subcutaneous injection. So you can subcutaneously inject corticosteroids into the keloid. Systemic administration, oral administration, is not going to help. You need to get it right to the place where the problem is in this instance. Severe osteoarthritis of the knee, you're going to do an intra-articular knee injection here. So you can dose steroid right into a joint, and it's going to help reduce inflammation in that joint. Will that also get absorbed systemically? Yes, of course. You're putting it into the body, you're putting it into the system, but it's going to work most powerfully at that joint. Asthma prevention, you're going to inhale. So you're going to inhale corticosteroids to prevent asthma attacks. Initial treatment of bacterial meningitis, we give IV steroids with the first dose or prior to the first dose of antibiotics in cases of bacterial meningitis to help reduce morbidity and mortality, really morbidity associated with bacterial meningitis. Psoriasis and severe eczema, here you'd use a topical steroid. So this would be topical administration. Allergic rhinitis, we would give steroid intranasally. And then poison ivy contact dermatitis, you're going to see oral administration of steroids in this case. So that's it for this quick review. Let's get back to your main lecturer.
So the next big topic to talk about is bioavailability. This is sort of another piece in the absorption puzzle. Bioavailability is defined as the fraction of the drug that you've administered that actually reaches the systemic circulation unchanged. So when you give a drug orally, how much of that drug is going to be absorbed, how much of it's going to get into the systemic circulation unchanged, still an active compound. For example, if you give a 100 milligram dose of the drug, but only 40 milligrams of that reaches the circulation, the bioavailability is 40%. If you give 100 milligrams of another drug and 90 milligrams of it makes it into the systemic circulation unchanged, then the bioavailability of that second drug is 90%. So it's pretty straightforward. Now the good news is this is not something you're going to have to calculate in practice. But you need to understand the concept because it explains why sometimes we have to give very large doses of certain drugs that have low bioavailability because you're trying to get enough of the drug into the systemic circulation to do some good. Unfortunately, we don't just get to magically come up with the numbers of, well, I know exactly how much drug entered the systemic circulation, so I can very easily calculate the bioavailability. It's a lot more complicated than that. If you look at figure 1.7, you'll see these curves of concentration over time. And you have to kind of compare the plasma levels of these drugs after you give oral administration, which is the bottom curve, which is a very flat curve, and look at the other curve is the IV administration. And you see that's a very steep curve because when you give the drug IV, all that drug is in the systemic circulation immediately. So the real way that you determine bioavailability is you use calculus to determine the area under each of these curves. And then you take the ratio of the area under the curve of the oral administration to the area under the curve of the injected drug, and that's your bioavailability, and you multiply by 100 if you want to give it as a percentage. So we're going to talk about some factors that influence bioavailability. First of all, there's that first pass hepatic metabolism that we've mentioned a couple of times. If you've got a drug that is absorbed readily, but it goes to the liver and it's broken down and deactivated and metabolized to the point of being ineffective before it gets into the systemic circulation, the bioavailability is going to be low. We mentioned nitroglycerin. If you give it orally, it's going to be metabolized to the point of being totally inactive by the time it gets to the systemic circulation. The next factor that influences bioavailability is the solubility of the drug. If a drug is too hydrophilic, it's just not going to be absorbed. It's not going to cross the cell membrane. But if a drug is too hydrophobic, it's not going to be soluble in an aqueous body fluid. And so if you want to have ready absorption of a drug, you need to have a mostly hydrophobic drug with some solubility, and that's why we use weak acids and weak bases. That's why those are the best drugs, because they need to be somewhat soluble in aqueous solution. The third factor that influences bioavailability is chemical instability. We talked about whether or not a drug is going to be degraded in gastric acid or be degraded by enzymes. Any drugs that's degraded is going to have a pretty low bioavailability, maybe even zero bioavailability if it's totally degraded. And then the fourth factor that influences bioavailability is the drug formulation. And this is what we're talking about: enteric coatings on drugs, or time-release drugs, or you use different particle sizes, or you use different salts. The idea is we can manipulate the drugs to make them more or less bioavailable. Sometimes we want it to be more bioavailable. We want it to be absorbed very rapidly. Other times we want it to be absorbed slowly for a time-release effect. So there are different ways to formulate drugs in order to make them more or less bioavailable. We need to talk about two other concepts: bioequivalence and therapeutic equivalence. And they sound similar, but they're not the same. So bioequivalence means two drugs have comparable bioavailability and comparable time to peak concentration. So you give these two drugs at the same time, they both have the same bioavailability, meaning the same amount still makes it into the systemic circulation unchanged, and they both have about the same time to peak concentration. So from the time you give the drug to when that maximum concentration is achieved is about the same amount of time. So that's bioequivalence. Now, therapeutic equivalence means that the two drugs have comparable efficacy and comparable safety. So two drugs may be bioequivalent, but they're not therapeutically equivalent because they don't have the same efficacy. So that's an important concept. So our next big topic is drug distribution. Drug distribution is the process by which the drug leaves the bloodstream and enters cells or the extracellular fluid. So we've got the drug out of the gastrointestinal tract and into the circulation, and now we need to get it out of the circulation and into the tissues or into the extracellular fluid where it can work. Because most of the time we're not asking a drug to do anything in the circulation, we're asking it to have its effect on specific tissues. So drug distribution depends on a lot of things. It depends on blood flow, capillary permeability, binding of drugs to proteins in the plasma and in tissue, and it depends on the hydrophobicity of the drug. Because the fluid we're talking about, the intracellular fluid, is aqueous, and the extracellular fluid is aqueous. So if a drug is very hydrophobic, it's not going to dissolve well in those aqueous solutions. So let's talk about each of these four components individually. So talking about blood flow is not equal to all parts of the body. In certain circumstances, your body is going to shunt blood to the brain or to the muscles or to the intestinal tract. So how much blood flow is going to the target organ is going to influence distribution of the drug. Capillary permeability is important, and this is determined by two things: the capillary structure and the structure of the drug. So talking about the drug first, we kind of mentioned whether or not the drug is hydrophobic or hydrophilic. Again, those hydrophobic drugs are going to pass very quickly through the cell membrane. In a capillary, you've got a basement membrane, which forms sort of the basic canal, the structure of the capillary, and then lining the inside of that basement membrane tube are your endothelial cells. And these cells, just like all cells, have this lipid bilayer membrane. And so the drug, if it's going to pass through the capillary and out into the extracellular interstitial fluid, it's going to have to diffuse through those cell membranes. So a hydrophobic drug is going to diffuse through those cell membranes much easier than a hydrophilic drug. And then we also have to talk about the capillary structure as a determinant of capillary permeability. Endothelial cells line the capillary, but there are places where the endothelial cells butt up against one another. And where they butt up against one another, they're formed slit junctions, which are just little gaps in this endothelial layer. So there's a little area where there's just kind of bare basement membrane and no endothelium. So at that little spot is a place where you don't have to be hydrophobic to pass through a cell membrane. The hydrophilic drugs can pass through those slit junctions and into the extravascular space. Now, in the brain, in the central nervous system, we don't have slit junctions. The capillaries in the brain form what are called tight junctions between the endothelial cells. And this forms what we call the blood-brain barrier. So lipid-soluble drugs can cross the blood-brain barrier because they can get through those cell membranes. But polar drugs, ionized drugs, those hydrophilic drugs generally do not enter the central nervous system at all. They cannot cross the blood-brain barrier, as we put it. Now, some drugs can be actively transported across the blood-brain barrier, but that's different than passive diffusion. And when we talk about capillaries in the liver and the spleen, they have slit junctions, but they're big, wide slit junctions so that you can move large proteins in and out. Think about what's the site of most protein production in the body? The liver. And so the liver has to be able to get its protein products, like albumin, for instance, out of the liver and into the hepatic capillaries so it can go into the circulation. So the liver and the spleen have very large slit junctions to allow big protein molecules and other big molecules to move in and out of the capillaries. So now it's time to talk about the concept called the volume of distribution. And volume of distribution is a little bit tricky. It's a hypothetical volume of fluid into which the drug is dispersed. Now, this is kind of fantasy land. It's not a real volume. It's a hypothetical volume. So we need to talk about the different water compartments of the body. And we're talking about averages, and this is on page 9 of figure 1.9. The body is about 60% water, about 3/5 water. So total body water is about 60% of your body mass. So very often in medicine, for some reason, we talk about an average 70 kilogram person. Now, 70 kilograms is about 155 pounds, which in the United States is certainly not average. That's lighter than the average American. But we'll talk about this average 70 kilogram person. So 60% of the human body is water, and that's 42 liters of water. If you were to take that 42 liters of total body water and pour it into a separate container, the first 2/3, or 28 liters, would be intracellular fluid, or the fluid inside the cells. The remaining 1/3 of total body water, or 14 liters, would be extracellular fluid, fluid outside the cells, including interstitial fluid and plasma. You could then pour the 14 liters of extracellular fluid into 2 separate containers, the first being the 10 liters of interstitial fluid, and the last would be 4 liters of plasma. And those are the water compartments of the body. So a drug can be sequestered in cells, or it can distribute into one of these compartments. It can distribute into the plasma compartment, or the extracellular fluid, or into the total body water. And let's talk a little bit about each of these components. So if a drug is distributed into the plasma, it's probably a large molecular weight drug, or a drug that's extensively bound to protein, because, again, those drugs that are bound to proteins are stuck in the plasma. They can't get out of the circulation. Or they're just big drugs that are too big to pass through the slit junction, so they stay in the plasma. And they have a relatively small volume of distribution because, again, only about 6% of your total mass is your plasma. So those are the drugs that have a small volume of distribution. Then we talk about drugs that distribute in the extracellular fluid. These are generally low molecular weight drugs, so they're smaller drugs, but they're hydrophilic. They can get out of the vessels through the slit junctions, but they can't diffuse through the cell membranes, so they cannot get into the intracellular space. They can get into the interstitium, but not into the intracellular space. So they stay in the plasma and in the interstitium, and that's about 20% of the body mass. The final group of drugs are drugs that distribute into the total body water. These are drugs that are, again, they're small, they have low molecular weight, but they're generally hydrophobic. So they can pass out of vessels into the interstitium, and then they can diffuse into the cells through the cell membranes. So they can distribute in the total body water, which is 60% of the body mass. So you can tell by some of the characteristics of the drug what types of volume of distribution it's going to have. So we need to talk about this concept of the apparent volume of distribution. In reality, most drugs don't just go into one compartment or another. There's a little bit in this compartment, a little bit in that compartment. The drugs can be bound by proteins, both in the plasma, as we talked about, and also proteins in the cells. They can bind to nucleic acids. They can bind to lipids. So we talk about the apparent volume of distribution, which is, again, sort of this theoretical volume of, in which the drug is distributed. We're going to talk about how we determine the volume of distribution. And I don't want you to focus on the formulas or the math at this point. I just want you to focus on the concept. Just stay with me on this. If you look at figure 1.10 on page 10, we're talking about distribution of drugs when there's no elimination. So you inject a drug, and all of it goes into the plasma, and it distributes according to its size and how hydrophilic or hydrophobic it is, like we've talked about. And so it distributes until the plasma concentration is at a steady state. And if you look at that graph, you see that steady state just kind of stays there because the drug's not eliminated. It's like you've taken the kidneys out of the patient, and so the drug has nowhere to go. It's just going to stay in the circulation indefinitely. In this circumstance, the volume of distribution is equal to the amount of drug in the body, which we represent as D, divided by the concentration, the plasma concentration of the drug, which we represent as C. So if you have 25 milligrams of the drug that you've injected into the circulation, and the plasma concentration is 1 milligram per liter, you divide 25 by 1, and you get a volume of distribution of 25 liters. Pretty straightforward at this point. But now we're going to have to start talking about mathematical formulas a little bit. And I don't want you to panic. There are only 4 mathematical formulas for pharmacokinetics, so only 4 equations that you need to know for step 1 of USMLE or level 1 of your COMLEX exam. If you can memorize these 4 equations, you'll be in great shape. These 4 equations are high yield, and I'll point them out as we get to them. There are 3 of them in the Part 2 lecture, and there's just 1 of them in this lecture, and we've just seen it. It's volume of distribution equals amount of drug divided by the concentration, or V sub D equals D over C. It's a pretty simple formula, but if you can remember that, you're guaranteed to get some questions right on your board exam. We've kind of got this fantasyland situation where the drug is administered, but it's never eliminated. Or maybe it's not so fantasyland. Maybe it's a patient who's on dialysis. They have no kidney function at all, and the drug is entirely renally excreted. So it depends on kidneys in order to be excreted from the body. So if you give that patient an injection of this drug, you can assume that it's all in the circulation. But in the real world, most patients are going to eliminate drugs. And they can be eliminated by the kidneys, they can be eliminated by hepatic metabolism, and so forth. So instead of the plasma concentration just staying level as it looked like in figure 1.10, it's going to taper off. It's going to decline over time. And that's what we see in figure 1.11. When you have first order kinetics, which is true of most drugs, this graph becomes linear when instead of just plotting it on a regular scale, you plot it on a logarithmic scale. And that's what you see in figure 1.12. So you can see that in 1.11 you've got this curve, and in 1.12 you've got a nice straight line because it's plotted against a logarithmic scale on the y-axis. To calculate the drug concentration when you have instantaneous distribution, as soon as you give the drug, the kidneys and other organs are going to start eliminating that drug, even while that drug is being distributed. You can use that plot where you've got that line, that straight line, that linear logarithmic scale. You can use that line to extrapolate back to time of 0, which is the y-axis. So you extrapolate back, as you see there on figure 1.12, extrapolate back to the y-axis, and that is what the concentration of the drug would have been if the drug was fully distributed as soon as you gave it. So you give the injection, and bam, the drug is distributed throughout all the tissues. And then as it's eliminated, you're going to see that normal elimination. You can use that initial plasma concentration in your volume of distribution equation. So that initial plasma concentration that you extrapolated back is C. And you use the dose that you gave, which is D, and you can calculate the volume of distribution using that same equation we just used. V sub D equals D over C. Now, we need to talk about what happens when there's uneven drug distribution between compartments. So this apparent volume of distribution we've been talking about assumes that the drug is confined to just one compartment. But we already said that's not the case. You know, there'll be a little bit of the drug in the plasma, and a little bit of the drug in the interstitium, and maybe some of the drug in the intracellular fluid. So the volume of distribution is not a real physical volume, but it's a ratio of how much drug is in this compartment and how much drug is in that compartment. It's a ratio of how much drug is in the extra plasma spaces compared to the plasma space. But this concept of volume of distribution is really useful because you can use it to calculate how much drug you need in order to achieve a desired plasma concentration. So Lippincott gives you the example of a drug digitalis, or digoxin, which is used for heart failure. It's an inotropic drug that's designed to help the heart beat more strongly. And this is a drug, it's a good one for their example because it's a drug that we often need to check drug levels on. It has a relatively narrow therapeutic index, which means you can be at the therapeutic concentration and just get a little bit higher and you're at a toxic concentration. So we have to monitor that level very closely and make sure we're not giving the patient too much drug. So if the drug digitalis is at concentration number 1, the initial concentration, which they note as C1, and you want to increase it to a desired concentration, which they're calling C2. The amount of drug that's in the body initially is the volume of distribution times C1. And the amount of drug that you need in order to get to the desired concentration is the volume of distribution times C2. And so you do a little algebra on that, and you just subtract C1 from C2, and then multiply that times the volume of distribution. And that tells you how much additional dose of the drug you need to give in order to achieve that desired concentration. Now, if you're confused already, I have good news for you. Not once in 4 years of medical school, 3 years of residency, 7 years of private practice, have I ever used any of this to calculate how much drug I needed to give a patient. It's just not something you're going to need to do. It's not really practical. But for testing purposes, if you're given the volume of distribution and you're given the other information, you can calculate what you would need in order to achieve a target concentration. It's a good test question. It's just not clinically useful. So you need to be familiar with it, and this is why this is one of those equations that you need to know for your boards and for your pharmacology tests. Now, volume of distribution affects the half-life. And this is a very useful concept. We're going to talk a lot about half-life in the Part 2 pharmacokinetics lecture. The amount of drug that's delivered to the site of excretion, whether it's the kidneys or the liver or whatever else, the amount of drug that's delivered to those organs is going to affect elimination. If a considerable amount of drug is distributed in the liver or another organ compartment, you would expect to have a large volume of distribution. So the drug is not being delivered to the site of metabolism and elimination very efficiently. You've got lots of drug out here in the liver instead of being in your vasculature and going to the kidney so it can be excreted in the urine. If you increase the volume of distribution and you start to allow that drug to be distributed into other compartments, you're going to increase the half-life of the drug. You're going to increase how long it takes to eliminate that drug, and you're going to prolong that drug's duration of action. So volume of distribution is very important, and we'll see it in the Part 2 lecture when we're talking about half-life.
Okay, now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time for you to read your pharmacology text that corresponds to the material that was just discussed. Then together, we're going to go through the quick review in your study guide.
I'll take routes of drug administration for 400.
In this route, drugs are absorbed by the rich capillary bed under the tongue.
What is sublingual administration?
That is correct again.
Take drug distribution for 800.
It's the hypothetical volume of fluid in which the drug is dispersed within the body.
Really? You two have no idea what it is? Not even a guess?
Yes, Trish, do you have an answer?
I gotta pee.
I'm sorry, that's incorrect.
What is the volume of distribution?
Right.
Drug absorption.
Wait a minute, I'm sick of this. You invite us over here to play a game with you that you know you're gonna win. What kind of egomaniac are you?
The best kind.
That's it, I'm sick of this. Come on, Trish, we got better things to do. Yeah, we got better things to do!
Sure you do.
Don't look at me, I'm just the host.
Okay, let's get through the answers to quick review number 2. Number one, if you administer 500 milligrams of a drug that has a bioavailability of 75%, calculate the amount of drug that reaches the systemic circulation unchanged. So you take a 500 milligrams of a drug, but only 75% of it gets into your circulation. So it's just 75% of that 500. So this is 375 milligrams. It's a very easy calculation. Number two, what is the equation for volume of distribution? The volume of distribution is equal to D over C, was the equation we saw. So D was the total amount of drug in the body, and C is the plasma concentration of the drug. And so just to clarify, the plasma concentration of the drug, it may be the plasma concentration that you actually have right now, or if you're using the equation in a different manner, it could be the target plasma concentration, the concentration that you want to get to. Number three, 50 milligram dose of a drug is administered IV to your patient, and her plasma concentration of the drug is 2 milligrams per liter. Calculate the volume of distribution. So since this drug is administered IV, you can assume that it's 100% bioavailable. It doesn't have to go through the enteric pathway to be absorbed. So you use all of that 50 milligrams because it's 100% bioavailable. So here you just take 50, which is your total amount of drug, divided by 2, which is the plasma concentration in the drug, and you get 25 liters as your volume of distribution. Number 4, complete the following chart of body volumes below for a 100 kilogram person. So we did this in lecture for a 70 kilogram person. This is important to know how these body compartments are compartmentalized for testing purposes. So your total body water is of course going to be 100% of your total body water. Liters in a 100 kilogram patient is going to be 60%. So 60% of your mass is water, right? Total body water. So this is going to be 60 liters. Intracellular volume is 2/3 of total body water. So the number of liters in this 100 kilogram patient would be 40 liters. Extracellular volume is 1/3 of total body water. So here we have 20 liters. Interstitial volume is 3/4 of the extracellular volume. So 3/4 of that 20 is 15. And then plasma volume is 1/4 of the extracellular volume. So that would be 5 liters. Number 5, compare the characteristics of drugs that distribute just into plasma rather than into the extracellular fluid or total body water. So drugs that distribute, they have a volume of distribution that's just plasma, are drugs that are either extensively protein bound or are a very large molecular weight, or of course any combination of those two. So extensively protein bound drugs and drugs with a large molecular weight, they can't really get to all of the body water compartments in your body. They're just going to stay in the plasma. Drugs that distribute into the extracellular fluid, the extracellular volume, we said was 1/3 of the total body water. So drugs that can get there are hydrophilic drugs. Hydrophilic drugs, water-loving drugs, drugs that dissolve very easily in water, and low molecular weight drugs, so they can get through the capillary beds and get into the extracellular volume. And total body water, these are hydrophobic drugs and low molecular weight drugs. So to be able to diffuse across plasma membranes, having some hydrophobicity, and being more lipophilic, so those terms are commonly used interchangeably. Hydrophobic, afraid of water, and lipophilic, fat-loving. So there's two different ways you can say that. So total body water, drugs that distribute into total body water, hydrophobic, and or very low molecular weight. And then number 6, when starting a patient on a new IV medication in the hospital, how would the dose be different if the patient was 100 kilograms rather than 70 kilograms? So the loading dose of a medication, we're going to talk about this in the next lecture, but the concept is very easy to understand. You have a larger patient here, has a lot more volume of distribution because their size is bigger. Bigger people have a bigger mass, also tend to have a bigger volume as well. And so the loading dose in this case would be larger than the patient that was 70 kilograms because the volume of distribution is larger. And that's all we needed to mention for that question. So that's it for this quick review. Let's get back to your main lecturer.
Another topic to discuss in drug distribution is the binding of drugs to plasma proteins. And we'll talk about this a little bit more in a moment. Drugs often bind to plasma proteins, usually albumin. And they bind reversibly, so it's not like they're bound to albumin and they're never going to come off that albumin. They're going to bind to albumin and then dissociate according to the concentration and so forth. But when a drug is bound to albumin, it can't leave the bloodstream. It's sort of stuck in the plasma. It has nowhere to go because those albumin proteins are too big to leave the plasma for the most part. So if you have a drug that has a high affinity for albumin, it binds very readily to albumin or other proteins, you have to give a much higher dose of that drug so that all the drug that's going to bind to albumin will bind to it, and then you have enough left over in the bloodstream to get out of the circulation and into the other tissues.